Welcome to the Maximus Podcast. I'm your host, Dr. Cam Sapa. As a clinical psychologist, medical school professor, and CEO, I specialize in helping men be better in mind, body, and masculinity. On this podcast, I interview extraordinary men as a clinician would, hearing their come-up stories of how they became the men that they are today, and having them share their secrets of actionable advice on how to look, feel, and perform your best. Dr. McClain is super excited to have you on the Maximus podcast. I'll do a little intro because you have a great background. So you're a licensed physician, got your medical degree at Western University, did your internship at the U.S.C. Keck School of Medicine, and you're considered a world expert in hormone therapy, anti-aging, regenerative, and sports medicine, which is the name of your private practice here in Santa Monica. So thank you so much for joining us.
My pleasure. That was a mouthful. I like to say we like to optimize health, to put it in a short and sweet version.
I love it. Yeah, we use that phrase of optimization here at Maximus as well. And we're very privileged to actually have you as a medical advisor to our company. And in fact, you helped develop our initial clinical guidelines, which was very, very helpful. So I'd love for you to tell us why you decided to work with us in terms of being an advisor.
Well, first of all, I feel privileged as well. I, as you recall, responded to your reaching out to me through an email. Mm-hmm. And when I heard about what Maximus was going to do, I thought, this is great. It's time. Mm-hmm. The asynchronous consultation part was something that had already been established, but that wasn't my main motivation. My main motivation was the purpose behind what Maximus is doing, which is, first of all, not just treating testosterone deficiency, but building a website and a program, if you want to call it that, mm-hmm. that encompasses men's optimization of health, not just one avenue. And of course, testosterone is a big part of that, right? Sure. It's a major avenue. But for everything from having a community, right, where there can be exchange of ideas and just commentary and whatnot, to really a different way of looking at things that's not just a paint by numbers medicine approach. I got interested in Maximus, and again, I'm privileged to be part of the board.
Awesome. Well, it's been an incredible contribution to what we were doing, and we love constantly iterating on our protocol, which you helped us develop. And we definitely believe in holistic health, which is why we address the behavioral to the pharmacological side of it. But why don't we start at the very beginning? Because I think, obviously most guys have heard of testosterone. They know it's obviously important for men's health and functioning. But I don't think they actually know what it is, what it does, and what the benefits are of testosterone. So why don't we do testosterone 101?
Well, I always joke with patients that, without making it sound like, and I know this is a generational thing, but the old Saturday Night Live skit for Shimmer, it's a floor wax. No, it's a dessert topping. Testosterone does a lot, not quite that much, but it really is important, not just for guys, but for women too. And that's a common misconception that it's just a guy's hormone. And ditto for estrogen, but I digress. For testosterone, it can be one of the key players in your energy, your libido, your general sense of well-being, or joie de vivre. Right. And those three, you could argue, are very personality-driven too. So in my practice, I've seen plenty of guys come in here and, they're bouncing off the wall with energy, despite having low testosterone, for example. But, they also have low libido, and they're having issues with moodiness and even perhaps depression. So those three, and there's many things. I'm giving us a sort of a summarization of what testosterone can do, because it can be linked to other things like sleep, both directly and more indirectly. But the key giveaway for me most of the time is seeing changes in body composition, because that arguably is influenced by your personality, because you got to get up and get off the couch and into the gym or on the road or whatever it is you're doing. But despite your personality, you can get in there and work your fanny off and not get any results. And that's typically when you know for sure that you have an issue, aside from just testing for it. Right. Which brings up a whole other conversation, as you probably will bring up, about testing and treating the patient versus treating numbers. But certainly those are sort of the four majors, of which, again, arguably three are personality driven, but the fourth is not. And that's what drives a lot of people in. Because they realize, man, I used to be able to just stop drinking beer and eating pizza for 3 weeks and get my abs back, but that's not happening anymore, and I'm training more than I ever have, and I'm going the wrong direction.
Right. Yeah. So I think those are really great points. And I think I've asked you this previously, like, why do people come to your practice, right? So, and you mentioned energy, libido, sort of general well-being, and also this just like body recomposition in terms of your efforts at the gym aren't paying off. You're not making the gains, so to speak, that you expect to be or perhaps used to be when you're sort of younger. Now, obviously, there's a lot of factors that could cause all of those reasons, but it sounds like, testosterone is sort of the master male hormone that influences a lot of these things. So that's very helpful for people to understand. So if they're noticing any of those particular symptoms that you mentioned, maybe useful to sort of get your testosterone levels checked. So why don't we actually talk about that, since you brought it up, in terms of like, unfortunately in standard primary care, it's not routinely checked. It's an unfortunate tragedy for why that is. But yeah, tell people sort of about the benefits of testing their testosterone, and maybe also how to interpret those numbers, because that's a very common question that we get as well.
Well, to your point, yeah, first of all, these things occur really at a certain point in life and can be exacerbated by other things like stress. And unfortunately, yeah, in mainstream medicine, we don't check for these things as often as we should. There's an expression I probably wear out. If you see a hoof print, you look for a horse before you look for a zebra, right? And unfortunately, in mainstream medicine, we're looking for everything but the horse. One of the things I also mention is we forget that age is probably the biggest risk factor for just about any dis-ease, right? But we don't talk about that because we can't influence that. We can't control it, right? We can influence our diet and exercise and whatnot. But by definition, I would say around about age 35, these things are going to start happening, meaning the symptoms we're talking about, some of the signs too. And you can certainly pick up on that with labs. That begs the question, though, at what lab value do you determine that someone is deficient, right? It is one factor of many, some of which we just talked about, in determining, hey, is this person a candidate or not, right? For example, there's a big range, a reference interval, if you look on standard laboratory assays of testosterone, depending on the lab, between, say, 200 and 900, just to use some round numbers. That's a big difference. And someone like you may be is comfortable around 750, let's say, and to get to 600 feels like the wheels fell off the wagon for you. Someone like me might be comfortable with 400, and if it goes to 350, I don't really feel that much difference. So you have to take it in conjunction with the signs and symptoms and what we call the patient's chief complaints. But yeah, testing is an integral part of all this because it can certainly support the diagnosis. And again, coming back to your point, there can be a lot of different reasons for, well, there's hundreds of headaches, right? There's a lot of different reasons for not having energy, libido, for being depressed, that may not have anything to do with testosterone. So it's definitely something that we should be checking on a regular basis.
And it's a great point that you bring up in terms of different guys at different levels can actually feel quite differently, right? Because of what they're sort of accustomed to. And I love the phrase that you mentioned in terms of we treat symptoms, not numbers. I think that for that reason at Maximus, we do a comprehensive sort of intake at the beginning, and we do testing, but we do it concurrently, essentially, with the treatment. We have people test their testosterone right before they go on treatment, so we have a clean baseline. But we don't necessarily use it as the sole diagnostic criteria, to your point, because, other factors are just as important. A common question that we get that I think would be very helpful too is people ask sort of what's the difference between total and free testosterone, and you can explain what albumin and SHBG is as well.
Well, boy, that's a difficult one to answer cleanly, if you will, because it's very difficult to test free testosterone. It's more of a complicated process than the way we calculate it, which is essentially what we're doing. We're not really testing it per se directly so much as we're calculating. You mentioned SHBG, sex hormone binding globulin. The total testosterone is something we can test more accurately, more, practically speaking, cost comes into this too, but more cheaply. And we don't need as much precision because we're dealing with a higher number. And what I should have probably said up front is there's a big difference between total and free testosterone. Total is what is available and potentially for use, whereas free is what's actually, well, like the name implies, free and available for use, and that's what's active in your body. And that's what we really are looking to. Because, for example, to go off on another sidetrack, there are plenty of people out there that have what we would call within normal limits and a significant amount of total testosterone. But the issue is too much of it is bound up. And sometimes all we have to do is unbind some of that. We reduce the SHBG and the patient feels better just doing that. We don't have to increase total testosterone and with that free testosterone. So free testosterone is the measure we now realize is what's most important to the patient. And again, because of the difficulties with getting a precise enough measure to be accurate, and I say that because remember, this is the smaller number, so precision becomes even more important when we're talking about accuracy. I guess we could argue, segueing from what we just talked about, that it's an integral part, but not the only essential part of the diagnosis, because it can be a little bit off.
Right.
That said, we do use it to rule out certainly some of the other causes that we were referring to outside of low testosterone, for example, for low energy. So if someone's got a free testosterone of, say, and this is another one that we laughed about before, right? Because depending upon if you're using, say, LabCorp versus Quest,
totally different.
Arguably, well, let's just leave it at that. It could be remarkably different by like a whole decimal point.
Yeah.
But I was going to use a number, let's say using LabCorp.
Right.
If someone has a free testosterone of say, 25 picograms per milliliter, you might look into something else for the source of their energy deficiency. Right. Because that's a pretty good number, right? Sure. So it all plays into we call our differential diagnosis, our list of possibilities. For like I said, with a hoof print, you look for a horse, then a zebra, a unicorn. But again, these are very helpful.
Totally. Yeah, one of the interesting phenomena that we found with our patients is it seems like the body almost adjusts to the SHBG levels that people have, in the sense that people who have low SHBG, like a level of 15, they tend to have lower total testosterone and a resulting amount of free testosterone. Folks with high SHBG, say a 50, have higher total testosterone. They end up having the same actually amount of free testosterone when you calculate it, as you mentioned. So it almost seems like the body's almost intelligent and kind of adjusts the testosterone because it knows how much is trickling through to the free. So on the basis of that, do you try to adjust SHBG up and down, or do you kind of leave it as is and then focus on just ramping up the total testosterone?
Without getting too Byzantine with an answer, it would depend upon the patient's diagnosis of either primary or secondary hypogonadism, right? Because at some point you could just say, well, if it's primary, we're just going to go to replacement. But if it's secondary, we can jigger those numbers more easily. So one approach is, let's say someone, they have that ratio, that relationship set up. Typically it's roughly 2% free to total. If it's 1%, well, then it makes a lot of sense to try and bring that up. And one way to do that is to reduce the body's perception of estrogen. We've seen that tends to raise the free T by lowering SHBG, including more protein in your diet. These are little tricks we know that can help jigger that. But of course, if that's not an option, or if it doesn't do enough, getting more juice for the squeeze, what we can do is just create more juice. And that's where we incorporate things like enclomiphene, other selective estrogen receptor modulators if necessary, to get the body to actually produce more of its own testosterone, so that what's available in that same relationship, that same ratio, is increased.
Totally. So before we talk about enclomiphene, let's talk about sort of the etiology of low testosterone. So the research has suggested that testosterone's declined about 50% in the last 50 years. Sperm count also has declined about 50% in the last 50 years. So there seems to be this huge generational decline. Forbes wrote a great article about it called "You're Not the Man Your Father Was" as a result of this, which is really,
which of course Dad would agree with, right?
Yeah, that's right. So what do you think is responsible for the decline in testosterone and fertility?
Well, from what I've seen, it's different than some of the studies I've read. And don't ask me how they actually weigh testicles at birth. But from what I've understood per the studies, the actual testicular weight at birth has declined over the last 50 years. The theory there was that certain what we call xenoestrogens, things that look like estrogen in the environment, have made for a decreased production of estrogen, a decreased production of testosterone. And whether this is affecting mom or the child himself is unclear. But in what I've seen in my generation is stress.
Yeah.
Stress kills. 300 years ago, our ancestors were herding sheep. And you would have a brief run of adrenaline if a wolf came by or an opposing tribe, but it wasn't everyday constant. And we've not, without going too far afield, this is more your area of expertise, obviously, but chronic stress is just, it's a hammer to the body. And, you know, the simple version is the fight or flight mode is very different than the parasympathetic mode that where we're going to be thinking about reproducing and repairing the digestive tract.
Right.
And the theory goes that if you're constantly in that mode, well, then you're not going to be producing much testosterone.
Right.
And contrary to popular belief, testosterone is not what you produce when you're threatened.
Yeah.
It's the preparation for. So you grow that muscle so you're ready when you're threatened. But cortisol and adrenaline and noradrenaline are what's produced when you're threatened. And when those are prevalent 24/7, you know, again, this is my experience with clinical visits of patients for however many years now. It buries your testosterone. And I've seen some, I mean, we joke, okay, well, you have a couple options here. You can move to Bali and become a beach boy, right? And reduce all your stress, which isn't an option for most individuals. But there are oftentimes ways that we can reduce stress. Something simple like, and we're probably going to segue into this anyway, but I'll jump ahead. Getting better sleep. And not just quantity, but quality. A lot of people, especially people that are overweight, suffer from sleep apnea.
Right.
So little things like that, it's not a little thing, but things that we tend to take for granted. If we adjust those, we can reduce the stress enough to bring testosterone levels back up. And one of the things that people often mistake too is, well, shouldn't I be working out because that's going to be the answer? That's going to create more testosterone.
Yeah.
Generally speaking, exercise is considered beneficial stress, eustress we call it, right? But when you're working for UPS in the high season and you're pulling 16, 18-hour days and you're physically, right? When I say working for UPS, I mean running a truck.
Right.
And then you decide to go to the gym, you've just piled on to that bad stress at that point with something that would normally be considered good stress. So I'm just trying to help smooth this out for people that are thinking this through, because we see this a lot, right, in practice where people take what's normally considered good advice, and it gets mistaken, I guess, or misinterpreted. But bottom line is stress can really affect the body's production of just about anything it's supposed to do properly.
Yeah, absolutely. And we talk about this in psychology all the time. Acute stress is not necessarily harmful, but chronic stress can be catabolic, right? And it antagonizes sort of the benefits of testosterone. So this is a huge point in terms of like, you know, stress reduction is obviously beneficial for not only holistic health, but hormonal health as well. You also mentioned the xenoestrogens. Is there anything that we can do about that? Obviously, we're kind of bombarded with plastics in our environment.
Yeah, that's a tough one because we found, I mean, last time I looked into it, we had literally hundreds of actually naturally occurring estrogens that we've identified, none that are naturally occurring testosterone analogs, right?
Yeah,
and that's interesting because, you know, these are all steroids to which we're referring because they come from cholesterol, right? So the cascade that begins with cholesterol in general categories, pregnenolone, DHEA, progesterone, testosterone, estrogen. The end of the line is estrogen, not any of these others. So it's interesting that the end of the line, you know, you could interpret that as, you know, the universe has us eventually becoming more, we'll call it female or estrogenized or whatever you want to call it, quite naturally. I don't know, but the only way I know of that you can defend against estrogen in any form, xenoestrogens, meaning, you know, things that are chemically similar and act the same way, is to block the receptor, which goes back to, you know, enclomiphene. That's what it does. So I'll stop there because you probably want to load that question for a different time. But that's the only thing I know of. And of course, you know, there are things you can do, meaning be aware of what products may contain xenoestrogens and avoid those. Don't cook with certain plastics that can
cookware,
leach that. So those things, you know, you can look into as well to try and protect yourself.
Absolutely. You mentioned earlier, which would be a good segue to enclomiphene, primary versus secondary hypogonadism. So can you explain to our audience in terms of what's the difference between the two and what's the resulting treatment that comes out of that differential diagnosis?
Sure. It's not always as cut and dried as primary versus secondary, but for purposes of our discussion, primary just means that the primary producer of testosterone, your gonads, and in males, we're talking about the testicles, is no longer functioning the way it's supposed to. So it doesn't matter how many signals it gets from, in this case, the pituitary sending a signal saying, hey, produce. The testicles are saying, we're done. That's primary. Secondary can result...
How prevalent is primary hypogonadism?
It's really age-related, as you can imagine, and we alluded to earlier. How prevalent, I guess it would really, come down to, age-related statistics, right? I don't know how to answer that other than that. And of course, I see different patients depending upon what they see me as treating. Am I more of a doctor that treats primary or secondary? So I really can't tell you, what the landscape looks like. But secondary hypogonadism is typically a result of the pituitary for whatever reason, including stress, for example, or something that sounds terrible but isn't normally terrible at all, a pituitary microadenoma, which is a fancy way of saying there's a little growth on your pituitary. If you remember your high school physiology, that's the master gland in the body. So that little organ right below the brain sends a signal called luteinizing hormone to the testicles to say, hey, make plenty of testosterone, ample amounts anyway. And if that's not doing that, that's considered secondary hypogonadism. Now, what's interesting about this is the body will not send a signal, the pituitary specifically, that LH I was talking about, to the testicles if there is ample amount of testosterone in the system, or if one of its metabolites, estrogen, is high enough, ample in the system. And I know most guys are going, wait a minute, that's a gyp. It is, right? From our standpoint. Because if you've got low testosterone and high estrogen, your pituitary will not send a signal to the testicles. And this is a good segue into this. And this is oftentimes what we see in practice with secondary hypogonadism. And that's the reason why our use of enclomiphene is a fantastic answer, because what enclomiphene does is it blocks the body's perception of estrogen so that body sees low testosterone and now low estrogen and says, okay, we can send a signal again.
So yeah, that's a really great point. And I think a lot of people aren't familiar with SERMs. In fact, they commonly confuse them for SARMs these days because it's a very similar acronym. And it's funny because online, sometimes you'll see a lot of guys say, if it's not testosterone, it doesn't work, right? TRT is the only thing that works because maybe they've never heard of SERMs. So can you explain a little bit more about SERMs, including enclomiphene, and maybe what's the difference between enclomiphene and Clomid?
Yeah, I mean, again, like I said, it's pretty simple the way it works. And certainly there are plenty of patients, I have plenty in my practice, that do just fine correcting for secondary hypogonadism. Maybe what these patients to which you refer are referring is the fact that with TRT, testosterone replacement therapy, your exogenous use of testosterone, you're overriding the system. There's no doubt that now you will have a certain level of testosterone or range in your system. With the treatment of secondary hypogonadism, remember, we're coaxing the system, the endogenous production of testosterone, to work the way it's arguably supposed to, right? Or the way we want it to anyway. So we're not going to get as narrowly defined results. You might have a spread. Maybe the pituitary doesn't react as well in me as it would for you when we're using this treatment. So that's where maybe there's some room for opinion about what works better than the other. But certainly, I mean, honestly, I've seen people, and I warn patients up front so that when they see the numbers, they don't go, oh my goodness. If I gave a 26-year-old male enclomiphene, a SERM, a selective estrogen receptor modulator, I might see a higher than normal testosterone level for a 26-year-old, something outside the reference interval, which is fine. And that's what you would see with testosterone replacement therapy typically too. And that's a whole other topic, but and so I'll leave it actually. But Enclomiphene is one of the isomers in what we call Clomid, the drug, which is clomiphene citrate.
Right.
And the problem with Clomid I've seen over the years, which by the way is used off-label here for testosterone treatment, is that there's another isomer in there called zooclomiphene, which tends to make people feel miserable.
Right.
And we're not sure why, but there's a theory that it tends to act on the estrogen receptors somehow. And a guy or a gal, if you're getting too much activation of estrogen, it can make you, let's just say, moody and irascible at best.
Right.
So with enclomiphene, which was officially pulled out back in 2015, one of these isomers from clomiphene citrate, we don't have that problem. So that patients, I have yet to see one patient say, oh man, that enclomiphene makes me feel miserable. Whereas, I mean, I've taken Clomid, clomiphene citrate, the combination myself, and within 3 days, 4 days, I felt like jumping off a building. It can make you feel miserable.
Right.
So that's maybe part of the reason you refer to people, poo-pooing the treatment of secondary hypogonadism. Yeah, if you were treated with Clomid, you probably said that was terrible.
Yeah. And the confusion, I think, lies in that clomiphene or Clomid is 62% enclomiphene. And so a lot of people assume, oh, well, they're very similar. What's interesting is that the research literature shows that over time, because the half-life of zooclomiphene is so long, that if you take Clomid for months, in fact, you're pretty much just taking zooclomiphene over time with a little bit of daily hits of enclomiphene. But the side effects tend to accumulate, interesting, over time. A lot of guys actually initially report feeling good on Clomid first, initially, and then it sort of degrades in terms of the benefits over time. With enclomiphene, because it's the pure isolated isomer, it's pretty much almost a separate drug. One's really almost an estrogen antagonist. The other is basically an estrogen agonist in terms of zooclomiphene's effects. And so they actually have very different effects over time. And to your point, that's why it's a lot cleaner in terms of side effects.
And that makes sense with the half-lives. I've read that too, that can make a difference. Although, again, for some, including me, you can feel terrible right off the bat.
Right, absolutely.
Yeah.
And the response varies. In the clinical trials, most, depending on the dosage, people got a 1.5 to 2.5x increase in terms of their total testosterone levels on enclomiphene. We've seen a similar thing in our practice. We, in fact, tend to use lower dosages. We typically start folks on 6.25 milligrams because we typically work with a little bit healthier population, usually in their 20s to 40s, some folks in their 50s. And we find, to your point about the 26-year-old, they don't need very much enclomiphene. Often, on average, we're seeing sort of a doubling of total testosterone levels just on the 6.25 milligrams. In fact, we had a patient the other day who had a 3.3x increase on 6.25 milligrams. It was a remarkable sort of increase. So the question for you, you mentioned sometimes it'll go slightly above the reference range, but you mentioned that it's not necessarily of concern. When do you decide it's too high, I guess, in terms of the reference range? Or is it really more based on people's symptoms and functioning? If they're feeling good, you're not concerned about like a 1300?
That's a great question. And before I answer that one, though, let me chime in on what you're saying about the relatively lower doses of enclomiphene. There's a flip side to that, too, that I want to mention, again, to chime in with you, what you're saying, which is you don't want to oversuppress the reception of estrogen in the body, because that can come with side effects as well. So you don't want to go necessarily headlong and say, oh, more is better. And certainly someone younger doesn't need as much. So, you don't want to rob Peter to pay Paul. And I'll just leave it at that. But I just want to add to what you were saying, because, that's true. And to your question about the levels of testosterone, the body works in what we call a negative feedback loop. So it's watching to see what the levels are, and it's saying, okay, it's low, so I'm going to send a signal to the testicles, make some more. Okay, that's plenty, and it stops sending a signal. With enclomiphene, the idea is it's going to work the same way. It's just not going to be regulated anymore by the level of estrogen like it was if estrogen is too high. The body didn't see it, so it's only going to regulate testosterone based upon testosterone levels. You go, well, how come it's going so high then? We don't know, but it does sometimes go higher. Now, are we just picking up on this because someone is complaining about symptoms of low testosterone, and otherwise we wouldn't be seeing a 26-year-old's testosterone assay in practice that sometimes does go higher? I tend to think it's probably a combination of both. because I've seen other assays, for example, of IGF-1, which is a reflection of growth hormone, which is also supposed to work on a negative feedback loop, that when we use it's called a GH secretagogue, something that gets the body to make more of its own growth hormone, we'll see some numbers that are supposedly physiologically not necessarily impossible, but very unusual.
Yeah.
Okay, so again, to answer your question, I think it's a combination. Is it risky? I've never seen any risk. And to that end, I would say that with TRT, if you wanted to use reference intervals, I would say for a male, you'd want to multiply the upper end of normal times about 1.6x. And you'll see, okay, that's a safe range as well as a clinical treatment range. So when it comes to endogenous production, if you're close to the top of the range, typically you're just feeling better.
Yeah.
The only other risk that we haven't addressed yet, and maybe I'm getting ahead of the game again, but what are some of the risks of raising your testosterone level? Really, based upon studies, it's not secondary to testosterone levels so much as what testosterone can be converted into. Now, the beauty of treating secondary hypogonadism with a SERM is that we're blocking the effect of its conversion to excess estrogen. Right? So we've got that covered. The only other metabolite that tends to be of concern occasionally is the production of excess dihydrotestosterone, which can lead to acne, can lead to inflammation of hair follicles, so male pattern baldness acceleration. Remember, that's got to be in your genes or not, but that's why I use the word acceleration. That doesn't occur in everybody. As a matter of fact, it occurs in the minority. But for that minority, that's something that would be a potential risk. But we do have a treatment for that too.
That's right. And one of the novel things about enclomiphene is when they look at the increase in testosterone and DHT, the DHT to testosterone ratio actually doesn't increase, as opposed to TRT, it seems to increase. So we always say, look, everyone's results vary, but enclomiphene should be actually much more hair safe or sort of prostate safe in terms of DHT, because it doesn't disproportionately increase DHT, and it maintains sort of like a 1-to-1 increase over time.
Absolutely. I can see that in practice too. Part of that goes back to the body liking this homeostatic range, we call it, right? And with TRT, like I just said, you're going to be at 1.6 times that.
Yeah.
And the body tends to, and I'm speaking anthropomorphologically about the body. Sorry, I got to spit that out. The body says, okay, that's way too high, and it will do almost anything to bring it back down into that. It can still be the upper end of normal, but it's got to get in that normal range. So it starts converting. The beauty of treating it, secondary hypogonadism and with enclomiphene is you tend to get to that upper end of normal, but you don't exceed it. You don't go to what we call supra-physiological levels, so you don't see that conversion that we don't see.
Right.
But you will see with TRT because of that phenomena.
Absolutely.
Yeah.
And you brought up a really great point about estradiol as well. So enclomiphene will increase your testosterone, but it'll also increase at least your serum levels of estradiol in terms of what's measured on a blood test. Right. Now, you've made a very astute observation in that that's not really interpretable, right, because of the estrogen receptor block. Can you talk a little bit about that? Because sometimes people get freaked out. They're like, oh, my estradiol is higher, at least on paper.
Right.
But they're not necessarily feeling that.
This goes back to the days before we had what we call aromatase inhibitors. Which were originally developed for women with breast cancer, right? The letrozole and then anastrozole. But yeah, it does get confusing because, because of Dr. Google to start with. Anyway, people read this stuff and they go, wait a minute, my estrogen's not supposed to be that high. But remember, with SERMs, selective estrogen receptor modulators, we are blocking the receptor. So the perception, if you will, of the pituitary or the body itself is that the estrogen is not there. We're blocking that reception. That's very different than we're blocking the production. Remember I said estrogen is a metabolite of testosterone. So it's convenient, honestly, to much more convenient to be able to use aromatase inhibitors. Okay, these things. Aromatase is the enzyme that converts testosterone into estrogen. Right. Most of that occurs at the liver, but can occur at fat cells and other places in the body. But then when you use that method, what you see is what you get. That's what's there. That's what's available. As opposed to, you see an estradiol level of 82, and you go, oh my God, that's 4 times normal. Well, that's what has been made, and we can measure that, but that's not what's being used. It's not effectuating changes in the body, because while it's still being made, we're saying, yeah, but we're not letting you do what you're supposed to do.
Right.
And the two are very different. Did I do a good enough job explaining that?
Yeah, no, I think it's a good point, right? When people take aromatase inhibitors, although it can also increase testosterone, it usually cuts their estradiol, their serum estradiol levels in half, right? And so sometimes people feel kind of wonky because they have low estradiol, and I always describe it as it should be a Goldilocks zone. You don't want it too high, too low necessarily. It has to be maintain that homeostasis that you mentioned. With enclomiphene, to your point, the levels are really uninterpretable because the estrogen receptor blockade, meaning it's not having that sort of action in the body. I'm curious in terms of, you use this obviously in your practice, enclomiphene, with patients who have secondary hypogonadism. Have you seen any ill effects in terms of hair loss or prostate? Because those are the two things that people ask us the most about, or any other potential sort of side effects.
With enclomiphene?
Yeah.
Ah, boy. And I mean, before I just blanketly say no, I mean, again, because you're not going to supraphysiologic levels, you're less likely to see, for example, more DHT being produced, which would accelerate, the male pattern baldness. It's kind of a difficult question to answer, technically, with 100% surety that I'm giving you, what is fact, because male pattern baldness is either in your genes or it's not.
Yeah.
And if you think about the people that that go through that, it starts to rear its head, pun intended, about 28 years old.
Yeah.
And it typically progresses pretty rapidly. So, was it slowed down? Was it affected by enclomiphene? Certainly not like it would be with TRT, I can tell you that, where we definitely see an increase in DHT. So I guess to that point, if we accept the fact that DHT is the prime mover and acceleration of what's in your genes, and we see that, no, DHT doesn't really go up that much with enclomiphene and just general treatment of secondary hypogonadism, then I think it's pretty easy to say, no, we're not going to have those kind of side effects like we would certainly with TRT anyway.
Right. And some of the other sort of common side effect questions that we get. So Clomid in rare instances has negative ocular visual effects, but because enclomiphene lacks that zuclomiphene isomer, it's never been reported in the research literature.
I've never seen it.
Yeah.
I've never seen any effects with Clomid, but I've never seen it with enclomiphene either.
Yeah. And some of the other questions, and maybe this is from TRT, there's no reported increase in hematocrit levels, or people get concerned about that or have to give blood on enclomiphene like with TRT.
Well, that's interesting because typically secondary hypogonadism is treated earlier in life. And one of the main drivers for the increased red blood cell count, hemoglobin, and hematocrit is sleep apnea. Now, there's a reason, red blood cells and hemoglobin need testosterone to be created, okay? A lack thereof can actually result in anemia, where you don't have enough hemoglobin. That's kind of our official definition, below a certain level. There are instances where if you go well beyond the physiologic level of testosterone, so with TRT, if you go well beyond a typical replacement dose, and certainly with anabolic steroids, I don't want to bring up a whole other case, but those are molecules that are very similar, but tweaked even more toward muscle growth, anabolism. But bottom line is that's even more testosterone. Then we can see some slight increases in hemoglobin and hematocrit just because we've added testosterone to the mix.
Right.
So it's important to say that because, again, with enclomiphene, we're not getting to those levels. Right. So I wouldn't expect that for that reason, but also because younger patients tend not to have anything leveraged by testosterone anyway, meaning the sleep apnea or any form of hypoxia. So, again, I can easily say that. And I was an accountant before I was a doctor, so I'm presumably honest and conservative. I've never seen a spike in hemoglobin and hematocrit, certainly outside of normal limits, using enclomiphene.
Right. And the other common questions we get are about, is this going to mess with my lipids? Is it going to mess with my blood pressure? Because obviously some folks do have hypertension or dyslipidemia.
Well, without going into the question of what's good and bad cholesterol, let's leave that for another day. But typically what we found is that and I'll couch this just in terms of what we kind of referred to earlier on in the discussion. If you're generally in better health, all these other things tend to come in line. So you're probably exercising more. You're probably more aware of what you're eating, fewer saturated fats. Again, I don't want to get too far into the weeds about what's good and bad cholesterol, but you should see your lipids improve. Let's focus on triglycerides, because that I can say we definitely want to keep those low. You're more likely to see a lowering of your triglycerides, even if it's something as simple as, now that I have some energy again, because I have my testosterone levels back up, I'm not reaching for the starchy carbohydrates for energy. Really simple as that. I've seen it time and time again.
Absolutely. So I think you did a really nice job running through all the potential concerns that people have, and actually how side effects are really minimal with enclomiphene. So let's talk about the benefits now. So in prescribing it in your practice and the clinical experience that you have with it, what do patients typically report in terms of the benefits, how they feel?
Well, the easy ones to tick off are, a resumption of their old energy levels, and I think it's important to enter into the discussion that, just because you may have more energy than your compadre doesn't mean that you haven't experienced a decrease. So that should be the focus of the patient, is how am I doing compared to me, my old me, let's say 5 years ago, versus, comparing yourself to somebody else. That's the wrong comparison. But yeah, seeing energy levels come back, libido. I mean, a 26-year-old who's not interested in sex. Yeah. That's unusual. And when we find out it's secondary to low testosterone, it's wonderful that can be fixed and they're back on track. Same with mood. I mean, we've known since the 1950s that testosterone is a natural antidepressant. Right. So to see their mood pick up, their joie de vivre, as the French say, return, that's wonderful. But also, and I started talking about this earlier, sleep, which can be secondary to stress, okay? The disruption in sleep, I should say. The rumination that occurs when you wake up as soon as you have enough energy to start worrying again, after the first 4-hour cycle, we'll call it. That resolves, because when you are feeling good and you wake up in the middle of the night, whether it's you're thinking about the car payments or later in life, when you're my age and it's 2.3 kids and a mortgage, you say, shut up, brain. Right. Go back to sleep. I'll handle it when I wake up in the morning, because I can. I feel good. And whether that's conscious or unconscious, subconscious, your body knows, right? I mean, we all know that. When you have the flu, your body, you can tell yourself you're feeling great, but your body goes, no, you're not. So simply restoring healthy levels, optimum levels of testosterone can affect something that you would normally not draw a line to and say, hey, my insomnia is gone now because I don't wake up and start ruminating. I go back to sleep and say, I'll handle it in the morning. Anxiety is another one, okay? Go back to that flu example. You got a stomach bug. I'm talking about a real flu. And you're down and out, and the world suddenly sucks. 10, 14 days later, you bounce back, and the world's great again. Well, the world didn't change. You did, right? Sure. So you get your body feeling the way it should, optimized again, and a lot of that anxiety goes away. And again, obviously the joie de vivre comes back, but those are some sort of side examples of things that get better when the therapy is instituted. So. And there's more. I mean, again, not to make it into shimmer. Sure. But, it all interconnects. And that's one of the things we know in medicine. The hip bone's connected to the knee bone, connected to the ankle bone, and they're all important. Yeah, absolutely. And that was the question I was really interested in, obviously, as a psychologist and psychiatry professor, was what's the effect on mood, right? And so we actually built in PHQ questionnaires into our intake, and we asked people again after 30 days because we want to track that over time. Which is a clinically validated mood questionnaire. That was one of the interesting findings that we found is most folks on enclomiphene do report decreases in depression and anxiety. Even though it's obviously we're not marketing it for that purpose, we're not using it as psychiatric treatment. But to your point, hormones have profound effects on the mind and body. And so people do report this sort of secondary benefit, if you will, in terms of mood, although it probably should be a primary benefit as well. Especially in this day and age. And again, who cares if it's primary or secondary, right? Because you could argue it's directly because of the hormone itself, or because now you have that energy to go and work out. And we were just talking about working out this morning. I mean, you feel better when you do that sort of thing. So it all comes together and snowballs in the right direction. Absolutely. Right?
And one of the other aspects of our protocol, and we call it a protocol because it's not just enclomiphene, is we try to provide people with the fat soluble or lipid soluble vitamins that are really important. So vitamins A, D, E, K, and GG or geranol. Can you talk a little bit about vitamin deficiencies, especially like everyone's vitamin D deficient these days, and why it's important for hormone production, immunity, etc.?
Well, not having the requisite components to run the system leads to stress and a breakdown of the operation of the system. So that's a very simple way of looking at it. And for example, D is an easy one.
Yeah.
300 years ago, I talked about it before, we were herding sheep. And so we were getting plenty of our source of vitamin D, which is sunlight. It works through the skin and the liver and kidneys to produce vitamin D, which is actually a hormone, by the way.
That's right.
And we found relationships with vitamin D and all kinds of protection from illness, everything from just general frailty and old age to colon cancer. There's been speculation that it's protective against COVID. I mean, it goes across the board. It's one of those very necessary hormones. The problem is, while 300 years ago, we were getting plenty of sun, life expectancy was on average closer to 30 years. So we weren't worried about these things I got growing all over me called skin cancers or precancers, right? From getting too much sun exposure. In evolutionary terms, our ability to compensate for that hasn't, and that's a blink in evolutionary terms. So we haven't developed a way to counter skin cancer enough. So the bottom line is, go enjoy the sun all you want for its mental benefits, you would agree, right? But wear your sunscreen and get your vitamin D from a pill form.
Yep. Yeah, absolutely. Yeah, and that's the interesting thing. The research has shown that sun exposure has secondary benefits beyond vitamin D, including lowering your blood pressure, which is really interesting through other mechanisms. But skin cancer is a risk, and people are surprisingly deficient. One of the data points I actually cite comes from your clinic. So we actually ran our first validation study right here in your clinic, where we measured people's hormone levels, testosterone, et cetera. But we also measured vitamin D because we were very curious about that. And interestingly, we found if you consider deficiency below 30 nanograms per deciliter, 66% of the patients who came through your clinic that we were testing in our validation study were deficient. And actually 100% were suboptimal if you consider optimal 50.
Yep.
I was in fact the only person that wasn't because I supplemented
Because you supplement, yeah.
Right, but it blew my mind. I was surprising to me because I was like, I know it's common, but I was thinking, well, LA, people get sunshine, it's so sunny here. But I was like 2/3 to 100% of people were below.
You'd be surprised. I mean, I see that times hundreds and thousands. People will say, "Oh, come on, doc, I can't be short on vitamin D," or "That's a bad number." I play 2 rounds of golf on Saturday and Sunday. Okay, so you're outside for 6 hours on a Saturday and a Sunday, probably clothed and with unless it's a weird golf course never heard of, and maybe with some sunscreen. That's nothing compared to the way we evolved being outside pretty much all day. Right.
Exactly. Yeah. And also in the wintertime, I actually recommend people, if they want to educate themselves, there's a free app called D-Minder. It'll figure out where you are in terms of your latitude and the time of day. And it'll tell you actually how much vitamin D that you're producing based on how much of your skin is exposed. And I always show this to people in the winter to educate them. And I say, look, right now, even in LA in, January, February, you're only producing like 1,000 IUs, even being out in midday sun for an hour. Now you can burn, the UV level is at a 4, but you're just not producing vitamin D. And I think back in the day, to your point, ancestrally, we probably accumulated, because it's stored in the fat, vitamin D during the summer. And then our levels probably dropped in the winter, sort of naturally. But now that everyone's deficient in the first place, we probably drop quite low. And that's why people get seasonal affective disorder these days, which is quite common. I actually, in fact, did an experiment where I went off my supplement to see, okay, well, what are my levels if I'm just getting natural LA sun? And I'm pretty, active in the sun, walk around without a shirt on if I'm working out in Santa Monica. My levels actually dropped down to 28. So it was below, it was deficient. And I was like, there's no way I'm going to be deficient, right? And then it obviously went right back on my supplement because I was like, this clearly works. And, at least when I take 10,000 IUs, I get into the 70s. In terms of vitamin D levels. So it's a pretty profound difference. And I think people totally also underappreciate the effect of vitamin D on mood. when people are deficient, as I mentioned, seasonal affective disorder, very, very common these days. People aren't aware that it actually may be one of the causal mechanisms for depression. And, in my practice, when I see folks, if they are depressed, I make sure that their vitamin D levels are sufficient. If it's not caused, to make sure to rule that out as a cause.
And even if we made the argument that, well, it's connected with the fact that you're outdoors and enjoying life, it still doesn't make sense to do it that way, because the studies have shown that, it was an old article, I think, printed in Mensa, that said the ideal is, because of UV radiation, right?
Yeah.
The ideal is actually to go out at midday when the sun's at its highest, wherever you are. Okay, and of course factor in your skin type and your latitude, but get somewhere between 15 to 30 minutes of sun.
Yeah.
Otherwise, you are frying your skin. There's only so much you can get in terms of your protective mechanisms being activated, melanin.
Right.
Okay, so with that alone, the argument is we shouldn't do it that way, even if it sounds good. Yeah. Go out and have fun in the sun, but use your sunscreen and take a pill.
Totally, yeah. And especially, because I'm sure you work on the cosmetic side as well with your patients. I always tell people, absolutely put it on your face and neck at the very minimum, because it clearly leads to premature aging and wrinkling. There's these funny pictures of truckers who literally one side of their face is more wrinkled because of the sun exposure that comes through their window, versus the other side of their face is a lot younger and more pristine. And I was like, if that's not evidence of photo aging, I don't know what is. It's a perfect control study. And
it looks even worse. There's something called a Canfield mirror, like the mirrors you see at the truck stops. Speaking of truckers, where you see every little blemish. It's even more distinct than we see, with the naked eye. I mean, you really do a lot of damage in the skin with sun, unfortunately.
Right. Yeah. So we talked about pharmaceutical medications like enclomiphene in terms of increasing testosterone. We talked about the importance of lipid-soluble vitamins in terms of making sure that there's no deficiencies that may be suppressing testosterone production. What about the lifestyle factors? What else do you counsel your patients that they should be doing? You mentioned sleep, for instance. What else just will make sure that they're doing everything that they can to have optimal testosterone?
It's hard, because as soon as you tell someone to reduce stress, you've just given them more stress. I've got to reduce my stress, right? But that's key. And really, you could lump them all into that category. Getting sleep makes up for excess stress. Certainly helps improve your reaction to it if you've gotten ample amounts of sleep. And by the way, that's 7 to 9 hours, depending upon who you are. And that's everybody, unless you've got a very, very, very rare gene disorder, DEC2 and maybe one other. So most people need that 7 to 9. And the thing is, I understand. I was one of them. You too, probably, even if it's just through medical school, where, 5 hours was a good night. And that was probably a good average if you got 5 hours during that course. It doesn't mean you're doing yourself good just because you can operate on that. And I always call it your reserve, and literally your reserve of stem cells manufactured in the bone marrow. There's an argument that certainly I've heard the hematologists make that, you're digging into your stores that will help you later in life. So that's one big factor, of course. The amount of exercise really depends upon the individual, whether you want to call it light or moderate. But again, going too far into exercise can create too much stress.
Yeah.
And that is relative. And obviously diet too. And it will help me sum up the concept, which, one size does not fit all. Not only in diet, but with all these things we're mentioning. And you gotta look at the time of the year, what's going on, in business, psychologically, but to just be aware of them, which I think is why you're answering the question, is important. And then from there, you can say, okay, well, I need to gauge my workout a little differently today because I was up 3 hours later than I thought I was going to last night. And, the boss was yelling at me on top of that because this was late and had to get done or whatever. So you got to be able to say to yourself, well, I'll speak for both of us. In our case, there's no Olympic medals on the line anymore. So, hey, how about taking care of the health? And maybe you just do a recovery day today because things have changed. But diet and exercise, I know that gets played up in the press. The problem with that is, in my opinion, over the years is going beyond that and saying there's one specific way is where it ruins it. And somebody says, well, I did that ketogenic diet stuff and it didn't work for me. It was it ruined me, and diet doesn't play a role in all this. Yeah, it does. That was the wrong diet for you.
Sure.
Try something else. Diet is very important. So is sleep. So is, your choice of profession. That's a tough one.
Yeah.
I've got a lot of law enforcement officers in my practice, and working the graveyard shift and alternating is even worse. Either become a vampire or don't.
Right.
But we have study after study that shows that is no bueno.
Right.
But how do you deal with that?
Yeah.
This is what they're doing for a living. Well, you encourage them to do whatever it takes to get on a regular day shift, or at least a steady one. But then we as physicians want to encourage them to do certainly all the other things as best they can,
Right.
and find other ways to compensate for that.
Yeah.
So whether that's maybe considering some more, say, antioxidants, or things that would be considered anti-inflammatory for someone who's not being able to get the requisite number of hours of sleep, for example, that's when you sweep out your digestive tract. That's when Mother Nature goes in and cleans things up. If they're not getting that, okay, well, maybe we'll use something that is protective, curcumin supplement, for example, the anti-inflammatory. So it's really just being aware of what these factors are and how to manipulate them, and that's what we're here for, right?
Yeah.
Is to help patients identify what the factors are for them and how to compensate for them.
Absolutely. And speaking of diet, I'd love to talk about animal-based versus plant-based diets, because I swear that 1 in 2 women I meet in LA is vegan or vegetarian. They all seem to congregate here. And then, interestingly, also, we even have patients. They all take athletic greens, these green supplements. There's this whole plant-based movement, and maybe some of that goes along with sort of the vilification of red meat, eggs, dairy, which seems to be very trendy lately. But I'm curious your point of view on this.
If you take the politics out, you removed a lot of the confusion. Okay. It's hard to evaluate diet because the studies are epidemiological.
Right.
Along with that, the study designs are typically necessarily poor, meaning that aside from just taking people out into a what do they call it, a biodome or whatever, and completely isolating them and saying, here's what you're getting today, you're dealing with recall. What did you really eat? And there's motivations for bias there,
Absolutely.
It was all that chocolate milk my mom fed me when I was older. That's the reason I'm fat. No, it's something else. Anyway, you get my point. So that's a tough one. But if we look at centenarians, the Blue Zone was an interesting book for me because, again, it was observational, though.
Right.
But you can go down to Loma Linda, for example, just down the road here, and they are very strictly vegan.
Right.
You go to Greece, though, the section in Greece where they live a long time, and there's dairy that's in their diet. You go to Costa Rica, there's meat. When they can afford it, they're eating meat.
Sure.
So I think it's a factor. I think most scientists believe it is a factor. Nutrition is important. The components have to be inserted into the system. But to what degree it affects longevity and overall health, I think you start with the individual person and their genetics, and then what they do for a living, and what age they are in life. And it makes it very, very difficult, which is why, to segue into something we can edit out later if you want to, but AI is going to become so important. That Star Trekian thing that just says all these things we can identify are health span markers, we'll call them, are being affected this way, and we know these are all the things that can affect them positively and these negatively, so we're going to include these and exclude these. I mean, it'll be something like that we come up with, because I really believe it's just not that simple. I've tried the diets, vegan. I had a blast. There's a lot of great foods you can make, and it's not just new mown lawn with some rice wine vinegar on it anymore. I mean, they've gone to extremes. I had the best chicken parmesan I've ever had at this vegan place, Crossroads Kitchen. But it's a lot of work for some, especially as an athlete, and maybe not for others. There are advantages and disadvantages to all of them, I would say, and you want to find out what fits best for you. I would argue that in the summertime, I'm more likely to enjoy vegan than I am in the winter, where I'm more apt to say, hey, whether it's the way we've evolved and it's just natural for me to say I'm in the winter mode, so I want to, or pre-winter, fall, and I want to fatten up for the winter, and I'm going to eat more fatty meats, for example. One thing I will say, though, we have plenty of evidence to support the fact that outside of races, where many a race has been won on white sugar. There's no doubt.
Yeah.
Or you want to throw wine and honey in there back in the early days of the Tour de France.
Yeah,
okay.
yeah.
But outside of that, sugar messes with the system.
Yeah.
So that's a dietary component I would say we know we should definitely exclude for better health. You know, you obviously need glucose, but not raw sugar. And we get plenty of glucose from the food we eat. And we want our body to learn how to break down proteins if necessary to get it, or use the starchy carbs in effective dosages, and that's it. Right. So that one I can say without hesitation. And there's a lot of good work by Gary Taub.
Yep.
He's not a doctor, but he's a great
journalist.
What do you call it? Investigative journalist who's written on that extensively and drawn upon the studies. So, you know, I'm not just spewing here.
Yeah. No, I had lunch with him actually a while back when he wrote Why We Get Fat, which is one of those best-selling books. Very, very eye-opening in terms of dispelling some of the myths that you talk about. And yeah, you know, one of the things I always say is like the one thing I hopefully all the religious camps of nutrition agree on is ultra processed food is probably terrible for us. Like the more highly processed the food, you know, it causes issues. And obviously eating whole foods, cooking yourself as much as you can feasibly is probably directionally correct, whatever your diet is.
If nothing else, it tastes a heck of a lot better. That's one thing I can say for sure. If you've caught fish, and back in my day when I was in Florida, radioed ahead to have Dad there with the fryer at the dock, and you put it in your mouth, or actually just eat it raw. I mean, you know, it's going to gross people out, but while it's still squirming, a little lime on there, it tastes different and it feels different. Now, you're the psychiatrist. You can tell me, is that in my mind, or am I actually feeling the difference? I don't know, but I would agree. There are some good research articles that show that the processing, if for no other reason that it eliminates some of the nutrients you're eating that food for, you know, is going to reduce its value to you for sure.
Yeah, absolutely. Yeah, and obviously the use of refined seed oils in restaurants is a relatively new phenomenon as well in terms of being very highly inflammatory. So I think the things that we always tell folks is, you know, at least make sure you're getting enough dietary cholesterol, because to your point you mentioned earlier, it is the substrate for all of your steroid hormones, right? If you're not consuming any cholesterol, it's and unfortunately, cholesterol got a bad rap. You know, people are afraid of eggs, which is terrible, even though there's no studies that really show that it causes any sort of long-term adverse health outcomes. So make sure you get cholesterol. And the brain needs animal fat. Omega-3s from animals are better processed. ALA is not really processed omega-3s very efficiently in plant-based diets. And so at least supplement if you're on one of those diets. But that's actually pretty critical to brain health as well. So make sure you're getting the right fats and fatty acids at the very least, whatever you do. Really
briefly, the analogy I use is to tell people that LDL cholesterol is bad is like saying that gasoline is bad.
Right.
Really? It runs my car, runs my lawnmower. I have 5 gallons in my garage for my chainsaw or to burn any of the bodies. But you know, it certainly isn't a good thing if you have a house fire, right? Or if you leave it next to your acetylene torch. And that's the source of confusion, I think, is that if you have plaque in your arteries, then we know that lowering LDL, with a statin or diet or whatever, will slow, stop, or even reverse coronary artery disease. But again, that's where the confusion is. Oh, LDL is high. Well, we better get that down. Well, who said?
Right.
If you don't have coronary artery disease, the saturated fats have been associated with, you know, better muscle growth, better sleep in some cases. So why would we eliminate them? And here's one that just fits for the non-health professionals, if you will, just for the masses that just put 2 and 2 together. If LDL were a driving force in this, as opposed to inflammation, or the spark in the case of my gasoline analogy,
that's right.
Then everyone who's been on a ketogenic diet in this country, and I say that because in this country, most people are, you know, doing the bacon thing. They call it dirty keto, all these saturated fats. And with the LDLs I see in my office, I mean, people would be dropping dead left and right.
Yeah.
So when I see an LDL that's high, particularly when someone's age is higher, which is the most important part of the assessment, other than actually getting the imaging, I will say, hey, you know what? We should probably look into this to make sure that you're okay and make sure you don't have any plaque in the arteries, which can be done very simply. It doesn't have to be a coronary CT angiogram. It can be a bilateral carotid Doppler ultrasound, which is just the waving of the wand over here, because there's a 95% correlation between what we see here, what's in the heart. So anyway, that was a long soapbox, but
no, it's important. I think because people do get their lipids measured as often as part of routine blood work, and I see it all the time. People are like, "Oh, my total cholesterol is high, my LDL is high," because they're eating usually like a animal-based or hypercarnivorous sort of diet, and they ask, "Is it cause for concern?" So you mentioned earlier, triglycerides are a much better sort of marker to look at in terms of something that's predictive of health outcomes. Do you look at any other ones that are particularly important, like a small particle LDL or ApoB?
In the right context, those are very helpful, right? ApoB, LDLP, and those could almost be interchangeable, right? But again, in a 26-year-old with no family history, and this is the lacking part, is that the most important factor. I don't mean predictive factor looking at age, is actually knowing what's in the arteries. And I think probably because, and I'm just riffing here or guessing, but it used to be, to get the gold standard to see what's going on in the arteries, you had to get a lot of millisieverts of irradiation. Okay, remember when you used to go to the dentist, or at least when I did, they'd ask you, have you had any dental x-rays in the last 5 years? Yeah, 3 years ago. Okay, well, then we'll wait 2 more years. Now they don't even ask you. And even physicians don't realize that nowadays, if you wanted to get a coronary CT angiogram for, how much do you weigh now?
175.
Okay, you probably would get 4.5 millisieverts of irradiation. So to get the gold standard, you go through 6 to 8 seconds with and then without contrast. Our living here in Santa Monica, you're getting 3.5 just for being alive. And the recommended maximum millisieverts per annum is 50. You plan on going to Europe? Well, probably not this year because of all the mess with COVID. But you're going to way more than that on a transatlantic flight. So you got to put it in perspective. And again, at 26, I'm not going to think about it unless there's reasons to, family history or whatever. But you get closer to 50, maybe 40, 45 if it's in your history, then it makes sense to go, maybe we should take a peek.
Yeah.
Now, where you draw that line, you could argue about all day long, because, well, do I want any to grow? Do I look at 30 just to be cautious? But my point being that it doesn't make any difference. It's not the protagonist, okay, until there is a spark. Then it can become a problem. Any more than, getting your growth hormone levels up for health reasons. Right? Unless you have cancer.
Right.
And then you probably don't want to get them up any higher.
Yeah, that's a good point. I always think you're on the very cutting edge of a lot of this, because you have a practice that's, as in your words, kind of focused on optimization and performance, especially in terms of the clientele that you see. What do you sort of see as the future of, like hormone optimization? Do you think we're going to increasingly see sort of non-suppressive therapies become more and more popular, more and more commonplace as they're kind of coming on the market? Or what do you sort of envision the next 10 to 20 years?
Politics aside, again, I'll say that. I think we're in for, I would love to be put to sleep on ice for a couple hundred years just to wake up and see how the advances we have. That would be so cool. And that's part of a big motivation for my sticking around. Not that I need more motivation, but we have so many cool opportunities coming down the pike, whether it's through gene editing, stem cells, strength, and they've used grip strength, they've used leg extension strength, but strength is correlated. I know correlation, you go, well, correlation. But what do you think medicine is mostly? We start there a lot of times, right? Even just to get a hypothesis. But strength is correlated with longevity, health span, healthy longevity, right? Not as much as VO2 max. But comparable. So you want to find that balance of having enough, and to your point, as a proxy for muscle mass, that's also associated with it. So again, I just gave you one good enough reason. Just muscle mass is a good enough reason to promote health span. But yeah, we go back to promoting health in general. If you're going to keep your VO2 max up, you're going to have to exercise, and ditto for strength and muscle mass, right?
Yeah.
And that, of course, folds into diet and rest as well. So a lot of things grandma said to do still apply. We can't get around those, but we have ways of leveraging those now. That's the word I like to use. By putting the testosterone back in the system, because Mother Nature in whatever her wisdom is that I don't understand.
Right.
I like to joke, it's natural to get sick and die one day. So who cares about natural?
Right.
Takes it away, we can put it back in and leverage all those good things again and get better life out of it. We call it squaring the curve in the anti-aging environment, right? So that instead of spiraling down into ill health, we keep going, and then one day we die.
Yeah, that's a great point. Yeah, and the word natural is thrown around a lot, and you can define it different ways, right? We actually talk about how enclomiphene stimulates your natural testosterone production, even though it's not a natural compound. It is stimulating the testes to produce more of its own. And then that way you're maintaining your LH and your FSH. You're maintaining your upstream hormones, as you mentioned, like the pregnenolone and progesterone are actually maintained because the whole hormonal cascade is maintained. And it works for
and your fertility.
That's
an issue for a lot of younger gentlemen that don't want to risk losing that, before they start a family.
Yeah, that's a great point as well, which on TRT causes infertility. It's a male contraceptive, in fact. Not completely effective, but enough so that...
Hear that out there, anyone on TRT. Do not count on that as, that you're actually shooting blanks unless you want a surprise. And yeah, even then let me hasten out also, it's usually just temporary. But yeah, this doesn't even go down that road when we're talking about this being, treating secondary hypogonadism with enclomiphene.
Right.
If anything, you want to be even more wary because you're increasing your fertility, and it's used off-label as a fertility treatment. So
that's right.
Careful out there, guys.
Yeah. Oh, speaking of which, I had a question I wanted to ask you, and I'm glad you reminded me of it. My understanding is that HCG is becoming hard to get these days. The FDA, I heard, was trying to classify it as a biologic, and so a lot of compounding pharmacies are no longer making it available. So I heard, at least from some other clinics, that they're no longer prescribing it. If that's the case, I don't know what you've been seeing or hearing out there. That's been the mainstay adjunct to TRT to maintain fertility in folks who want to maintain TRT. Are we going to see alternatives or substitutes for HCG, perhaps enclomiphene or other things?
Good question. First of all, in terms of HCG, it's no compounders allowed to make it. Mm-hmm. So the only HCG that is allowed to be prescribed is brand. And I don't understand any of this stuff, because if it were motivated by profit, then you would think that the brands would have created enough of it to go around. We're experiencing a shortage of HCG right now, which is unfortunate because a lot of people need it, not just for cosmetics, for people that are on TRT and don't want their testicles to atrophy. But to answer the other part of your question, we don't have any really good alternatives, because the alternatives typically involved, gonadotropin releasing hormone analog that requires, 4 jabs a day subcutaneously, or something like kisspeptin, another peptide. It's just too much work, and it's not nearly as effective. It's not as effective at all as the HCG. And no, we don't have real alternatives. Like enclomiphene won't work because, remember, in the example I used, if your testosterone levels are high or your estrogen levels are high, your body will not send a signal. So we can block estrogen, but remember, someone on TRT, the testosterone is high, so simply blocking the receptor with a SERM is not going to work. You have to actually override the system with HCG, which is, by the way, it's not even an analog. We call it a homolog of LH. Yeah. So it's the only way. I mean, that's why it's so important that we keep it around. Mm-hmm. However they want to classify it or whatever. Right. The problem is when the compounders can make it for significantly less than the manufacturers can make it. And again, politics aside, I don't know about all that stuff, but we need HCG around for sure.
That makes sense. And people often compare HCG and enclomiphene, and correct me if I'm wrong. My understanding is because HCG is a homolog of LH, it basically functions as like a synthetic LH. Does it suppress endogenous LH production while enclomiphene essentially stimulates endogenous LH production?
Yes. Again, it's because it's a homolog. They actually have receptors in the brain that are called, LHCG receptors. Mm-hmm. That's how closely knit they are. And I should have, I can look into the weeds. I want to say they're like one ligand different, or I don't know. It's very, very close anyway. Yeah. But I mean, you'll see someone on HCG and their LH will be nil because you're not picking up HCG. I mean, again, and that goes into laboratory assays. Mm-hmm. They can differentiate the two well enough, even though they're that close. But to answer the other part of your question, yes, enclomiphene will increase your LH production. Sometimes actually, more often than not, it's super physiologic. You'll see an LH that's off the charts.
Yeah.
Which is fine.
Absolutely. Awesome. Well, this was a super riveting and informative conversation. You have such a wealth. I think you've been in practice for 35 years now. So
I have been involved in health for a long time.
For a long time.
But yeah, I'm in my 60th year now of life. How's that?
Amazing. Yeah. And obviously, you've seen probably tens of thousands of patients at this point. So, we love having our medical advisors like yourself, Dr. Eugene Shippen, and the rest of the folks on to, inform our audience and share kind of your wealth of knowledge to the general public. So thank you so much for spending time with us.
My pleasure to be associated with the group and also to be associated with the other medical advisors we have. Like you mentioned, Dr. Shippen, he's great. He's been around. I can say he's been around longer than me.
That's true.
And
he's
knows
in
more
his
than
50th
me.
Year of practice, actually.
Yeah, no, he's great. And he's a guy that thinks outside of the box. I think all of our group thinks outside the box. Even if they were trained, very strictly mainstream. So we got a great group.
Awesome.
Very excited about our prospects going down the road here.
Thank you very much, and I think you're instrumental in making that happen. So thank you again, and hopefully we'll do some more of these in the future in terms of maybe some focused topics. I'd love to actually do a whole segment on hair loss, hair and beard growth, and all the interesting sort of hormonal approaches to that. We actually had Wayne Hellstrom talk about all the PDE5 inhibitors and sexual health. So those would be great future topics as well.
Anytime.
Awesome.
As you
Thank
can tell,
so
I'm
much.
not short for words.
Yeah, that's right.
For better or for worse.
Awesome. Well, thank you again.